introduction and definition, sickle cell disease is an inherited disorder that occurs due to point mutation in the beta globin chain, resulting in the production of sickle hemoglobin S, that tends to become rigid and then becomes sickle-shaped under low oxygen concentration. These sickle-shaped RBCs obstruct the blood vessels, leading to reduced blood flow to various organs, causing ischemia and tissue fibrosis. Also, these sickle RBCs, being abnormal in shape and frequently sequestered by the spleen, creating a state of chronic anemia in the body. Also, as a result of being fragile, they are also prone to hemolysis, which also contributes to the chronic anemia that we have in patients with sickle cell anemia or sickle cell disease. Sickle cell disease is a genetic hemoglobinopathy associated with extensive morbidity and early mortality. While there have been recent improvements in the available disease-modifying therapies for sickle cell disease, cardiopulmonary complications remain a major risk factor for deaths in this population. Unfortunately, existing guidelines regarding screening, diagnosis, and management of cardiopulmonary complications are limited because of lack of high-quality prospective longitudinal data in sickle cell disease populations. Now, sickle cell cardiomyopathy refers to a range of abnormalities including diastolic dysfunction, cardiac fibrosis, prolonged repolarization, and autonomic system abnormalities that contribute to the development of heart damage and dysfunction. It presents as a variant of restrictive cardiomyopathy with left ventricular dilatation and preserved LV systolic function in most cases. Now going to epidemiology, the true prevalence of heart failure and possibility of ventricular arrhythmias remains unknown in sickle cell disease. Part of this absence can be explained by the under-recognition of sickle cell cardiomyopathy, and most studies are limited by small sample sizes. The combination of health disparities and gaps in care, as well as the challenges in assessing advanced cardiac imaging like CMR, all results in a paucity of reliable epidemiologic data. While prospective large sickle cohort studies are sparse, these investigators, parents, and colleagues found at least 2.5% to 3% overall prevalence of elevated filling pressures during right heart catheterization in sickle cell disease patients. Now, moving to pathophysiology now, since its origins, cardiac pathophysiology in sickle cell disease has largely been attributed to anemia and the resulting high output heart failure. Because of reduced oxygen carrying capacity from anemia, the body tends to compensate by increasing the cardiac output, the stroke volume, which eventually leads to dilatation of the peripheral vasculature, resulting in low systemic vascular resistance. Hello, am I still audible?
Yeah, you're loud and clear, please. Go ahead.
All right. Yeah, thank you. Subsequent activation of the, with this low systemic vascular resistance, there is activation of the renin-angiotensin-aldosterone system, which further results in fluid retention, volume overload, and increased wall stress. Also, chronic volume overload from chronic transfusion contributes to the development of cardiac chamber dilatation, hypertrophy, elevated filling pressures, and subsequently high output heart failure that we see in sickle cell patients. This description that I just mentioned now has been however, recent published works with recent published works, the concept of sickle cell cardiomyopathy has emerged beyond the phenomenon of high output cardiac heart failure. So this entity further incorporates diastolic dysfunction, the sickle cell cardiomyopathy. Apart from the high output heart failure, there is also diastolic dysfunction, cardiac fibrosis, relatively prolonged repolarization, which present with prolonged QTC. And then we have autonomic nervous system abnormalities, which also present with reduced heart rate variability. So these are other entities that have been incorporated into the pathophysiology of sickle cell cardiomyopathy, apart from the whole high output heart failure. So these traits can contribute to the development of heart failure with preserved ejection fraction in patients with sickle cell cardiomyopathy. These are a diagram showing the pathophysiology of the of sickle cell cardiomyopathy. On the left is showing how the pathophysiology of the LV dilatation, which starts with chronic anemia. With chronic anemia, there is compensatory high cardiac output, and then there's also peripheral vascular dilatation just to meet the tissue oxygen supply. And then with this, there is activation of the renin-angiotensin-aldosterone system, causing water and salt retention, which culminate into volume overload, causing increased cardiac preload. This leads to cardiac remodeling, predominantly LV cavity dilatation associated with compensatory eccentric and myocardial hypertrophy. However, on the right here is showing the mechanism of the restrictive physiology, cardiac physiology, which is actually as a result of myocardial fibrosis. The fibrosis actually as a result of sickled RBC in blood vessels, which causes microvascular occlusion, reduced perfusion, and then ischemia and fibrosis that we have, which causes stiffening of the LV walls, causing diastolic dysfunction, which is the basis of the restrictive cardiomyopathy that we see in sickle cell cardiomyopathy. Also on pathophysiology, why hemolysis, vaso-occlusion, ischemia, reperfusion, and systemic inflammation are all marks of sickle cell disease, their links to sickle cell cardiomyopathy remain unclear. Similarly, why transfusion burden and iron overload are common in sickle cell disease. In fact, in the past, it's been hypothesized that iron overload is also part of the pathophysiologic mechanism of sickle cell cardiomyopathy. However, recent studies using CMRI have confirmed that the absence of significant myocardial iron deposition in the majority of patients. Based on series of articles, a diffuse pattern of cardiac fibrosis seems to be associated with both the degree of hemolysis and diastolic dysfunction. Similarly, prolonged repolarization also seems to be associated with hemolysis burden in this group of patients. However, mechanism that contributes to prolonged QTC and cardiac fibrosis, changes to the action potential and arrhythmogenic propensity are largely unknown. Microvascular occlusion contributes to organ damage in sickle cell disease. Measurement of microvascular blood flow in patients using CMRI or contrast-enhanced echocardiography has detected abnormal microvascular blood flow in the hearts of patients with sickle cell disease. Also, additional studies have suggested genetic contributions to the development of sickle cell cardiomyopathy traits, including diastolic dysfunction and QTC prolongation. This is also a diagram showing pathophysiology of sickle cell cardiomyopathy, just as I explained earlier. The summary is just that there are two pathways the chronic anemia pathway leads to LV dilatation and eccentric LVH, which results in the high output state. Also, the microvascular vaso-occlusion, pro-fibrotic signaling leads to myocardial fibrosis, which is responsible for the restrictive physiology that we see. And then the cardiomyopathy is a combination of these two entities. And these are the hemodynamic changes that we see in sickle cell cardiomyopathy. There is increased LA volume, increased pulmonary arterial pressure, and increased TR velocity. Also, clinically, they present with early mortality. It predisposes patients to dysrhythmia and then sudden death. Also, another important association with sickle cell cardiomyopathy is the issue of pulmonary hypertension in sickle cell disease. The pathophysiology of PH in sickle cell disease is complex and is a significant cause of mortality and morbidity in patients. There are several mechanisms involved in sickle cell disease-related pulmonary hypertension. First is that as pressure is a product of vascular resistance and flow, high cardiac output causes increased pulmonary pressure, regardless of whether pulmonary vascular resistance is high or not. Also, the chronic volume overload subsequently causes high pulmonary venous pressure. Then nitric oxide scavenging by free plasma hemoglobin can cause intravascular hemolysis, which can induce endothelial injury, which can cause pulmonary arterial vasculopathy. Now, out of these three mechanisms, two are directly linked to the hyperdynamic state due to the chronic anemia in this patient. However, generally, as we explained earlier, pulmonary hypertension in sickle cell disease will actually fall into any of the WHO clinical groups. It could be as a result of pulmonary arterial hypertension from the vasculopathy. It could also be from, that's group 1, that's group 1. Then group 2, it could also be from the left heart disease, high filling pressure, early filling pressure, that's group 2. Then also the fibrosis, the myocardial fibrosis, the fibrosis in sickle cell disease is not limited to the heart. It can also occur in the lungs, and they are also prone to acute chest syndrome, which also has some infarctive component. So they could also have pulmonary fibrosis, which could also lead to pulmonary hypertension, which will fall into the group 3. Also, with the endothelial dysfunction, they can also they are said to be prone to thromboembolism, and then they can have the group 4 pulmonary hypertension. However, generally they are listed under group 5, which is of unknown or multifactorial etiology. So they are listed under group 5 of the WHO clinical groups. In sickle cell disease, diastolic dysfunction and pulmonary hypertension each contribute independently to mortality, and patients with both risk factors present have very poor prognosis. Combination of sickle cell cardiomyopathy and pulmonary hypertension actually leads to poorer prognosis in this set of patients. This is just a diagram showing the various sickle cell disease patients. I will not go over this. I've mentioned most of it. Okay, so typical symptoms of pulmonary hypertension includes dyspnea on exertion, kind of right heart, heart failure, elevated JVP, loud P2, fluid retention, peripheral edema. However, these symptoms may also be attributable. They are similar to what we have with chronic anemia. They can also have dyspnea on exertion. Then the LV dysfunction with the diastolic dysfunction, they can also present with all these symptoms. So all these symptoms will actually be from other comorbidities aside pulmonary hypertension. And then assessment of functional capacity with a 6-minute walk test is important, and also BNP, NT-proBNP levels, as well as assessment of right ventricular systolic pressure via echocardiogram is also important, and is used to identify patients with sickle cell disease at higher risk of pulmonary hypertension. As we know, echocardiography cannot definitively diagnose pulmonary hypertension. We need right heart catheterization, which is the gold standard for the diagnosis. Echo will just tell us the probability, whether it's low, intermediate, or high probability of pulmonary hypertension. The mainstay of therapy for pulmonary hypertension in sickle cell disease includes maximization of sickle cell specific therapy, which includes hydroxyurea, transfusion, stem cell transplantation, and the treatment of hypoxia with supplemental oxygen therapy, and also treatment of associated cardiopulmonary conditions. Chronic red blood cell transfusion, as opposed to whole blood transfusion, has been shown to reduce pulmonary pressure and increase 6 minutes walk distance and functional classification in patients with sickle cell disease and pulmonary hypertension. However, there is limited data on specific treatment of pulmonary hypertension in sickle cell disease, and the choice of agents is empirical and based on the safety profile of the medication and the physician preference. So now going back to sickle cell cardiomyopathy, how do we evaluate and manage? There are no current guidelines for screening, diagnosis, or management of sickle cell cardiomyopathy based on the paucity of epidemiologic and treatment data. Essential investigation tools include the echocardiography, cardiac MRI, and right heart catheterization. While the defining traits, including diastolic dysfunction, cardiac fibrosis, prolonged QTc, autonomic dysfunction, have all been reported by several studies to represent potential biomarkers for poor outcomes. Whether they reflect modifiable risk factors remains largely unknown. Nevertheless, the compensated heart failure protocols have been well defined for the broader population, including those patients with sickle cell disease. So meaning when they present with heart failure, whether preserved or reduced, we can manage them with guideline-directed medical therapy for general heart failure. However, volume management via the use of diuretics has to be carefully tailored, as patients typically need to remain in a relatively tight euvolemic range so that we don't tip them into dehydration, which can predispose to vaso-occlusive crisis, or volume overload, which can result in decompensated heart failure. Treatment of any underlying risk factor like hypertension is also prioritized. While no approved therapies exist for heart failure with preserved ejection fraction in the case of sickle cell disease, of sickle cell cardiomyopathy, and angiotensin-converting enzyme inhibitor or mineralocorticoid receptor antagonist is generally considered for relative hypertension and sickle cell cardiomyopathy. Of course, we can go ahead with the pillars of management of heart failure with preserved ejection fraction, which involves treating the comorbidities, SGLT2 inhibitors, and diuretics. In conclusion, sickle cell cardiomyopathy is a unique restrictive cardiomyopathy characterized by diastolic dysfunction, early enlargement, and normal systolic function with LV enlargement. Similar to other restrictive cardiomyopathies, the sickle cell disease related cardiomyopathy may predispose to arrhythmias and sudden death. Diffuse myocardial fibrosis has been shown to be the underlying mechanism of the restrictive cardiac physiology of sickle cell disease, and definitively establishing the mechanisms underlying diastolic dysfunction and sickle cell cardiomyopathy may lead to specific targeted therapy to slow or reverse the cardiomyopathy and decrease the morbidity and early mortality of sickle cell disease patients. Thank you for listening. These are my references. Thank you.
Yes, thank you very much, Dr. Olosho, for a very concise presentation. So I would open the floor for questions and comments from participants. As the floor is open for questions.
Hello.
Yes, go ahead.
Dr.
Right.
Olosho, thank you very much. I don't know, is there any therapeutic intervention that we could use for sickle cell cardiomyopathy before I make further comments? Thank you.
Well, thank you for the question. In the guidelines, there are no recommendations yet in most of the guidelines for a specific therapeutic intervention for sickle cell cardiomyopathy. However, expert opinions, people have said with the vasculopathy that people have tried calcium channel blockers, and also with the remodeling, and people have also tried angiotensin receptor inhibitor, ACE inhibitor, ARBs, mineralocorticoid receptor antagonists, but they are yet to be. The studies are still possibility of study to actually put this into the guideline. However, when they present with heart failure, we treat them with the guideline-directed medical therapy. Then also the treatment of the comorbidities, and also sickle cell-directed treatments, hydroxyurea, have been seen to help the cardiomyopathy. Thank you.
Thank you.
Okay, thank you.
Go ahead, Florence. I'll talk after that.
Okay, I just wanted you to help me recap the pathophysiology. I was a little distracted then. Is it related to vaso-occlusion? I just need to know, because that's what I was thinking of. The pathophysiology of cardiomyopathy, like just to recap, sorry.
All right, so this diagram can also is a summary of the pathophysiology, and we have two arms. We have the two components of the cardiomyopathy of sickle cell is a variant of restrictive cardiomyopathy. However, we know that for restrictive cardiomyopathy, they have bilateral enlargement, and then the ventricles are fine. However, for sickle cell cardiomyopathy, we have dilated left ventricle, and sometimes we have dilated RV too. And then the explanation for this is that chronic anemia actually causes LV dilatation in them, eccentric LVH, and this and also because of the anemia, there is compensatory increase in the cardiac output and stroke volume, which leads to the high output state in them. So, and then the other component is the restrictive physiology, which is as a result of microvascular, vaso-occlusive, and myocardial fibrosis that eventually occur in them with the vaso-occlusion. So that's basically the pathophysiology.
Thank you, Dr. Olosho. Florence, just I wish I could be as brief as possible. In sickle cell, two major pathophysiological mechanisms are in place, just as I just highlighted. One is chronic anemia. Then the anemia can be as low as, in fact, over 50% of the people I've seen maintain their steady state at about 6 grams per DL, and they are fine. So they are in steady chronic anemia, and because of that, they usually have volume expansion and expectedly ventricular dilatations. Now, these guys equally have endothelial dysfunction with microvascular thrombosis and microinfarcts. All manner of myocardial infarction is seen in sickle cell anemia. They could be patchy, they could be diffuse, but they are rarely transmural. Most of them affect the endothelial area. And because of this punctate, numerous, and recurrent microvascular ischemia and fibrosis, they eventually go into this restrictive state because of the fibrosis. Now, has equally been noted that the sickle cell anemia patients developed both pulmonary and systemic hypertension at a relative lower pressure to the general population, even though they usually have generally lower blood pressure. But what will look like relative normal blood pressure in them is already hypertensive with end organ damage, including renal nephrosclerosis. Now, so these sickle cell anemia patients are very unique people. So the effects in the heart are in two folds. One, dilatation from the chronic anemia. Two is all the forms of ischemia and fibrosis that goes on in the heart. Now, for that reason, the sickle cell anemia patients have penchant for arrhythmias. Indeed, a good number of them, after the pulmonary hypertension, the second commonest cause of death is heart failure and usually sudden cardiac death. Though there are a handful number of studies in our environment, but it has not been able to be generalized, such as we developed a strict guideline. Now, the known so far treatments for this cardiomyopathy, the best treatment is usually that of preventive, using things like hydroxyurea. I think there are more agents that they've developed recently that I've not, I can't remember them now. But hydroxyurea works. However, you remember that hydroxyurea is teratogenic. So we've not been able to find a single agent that cuts it all. So if you use hydroxyurea in males, we may not be able to use it in females because of, we don't know when the lady will take in, except she's strictly on what's it called? Contraceptives. So what we know so far is just the use of preventive to maintain the fetal hemoglobin percentage higher, because the fetal hemoglobin or those factoid formation and the microvascular clogging and the ischemia. For the restrictive cardiomyopathy, treatment is essentially the same. But from the few experience we've had, it is good that these people should equally be maintained on beta blockers, as that is the nearest thing we can use to assist us against the possible arrhythmias that come in. I have never seen bradyarrhythmias among them. Most times it is usually tachyarrhythmias. And of course, except there are bundle branches, conduction branches, conduction abnormalities. Of course, that can only account for, otherwise it is usually tachyarrhythmia. I think let me stop here. If there are a few other things, if I could still remember, I may be able to address it. My dissertation was on this. Thank you.
Yeah, thank you so much for the comments. Please go on, Dr. Conte.
Yes, we have some other comments on the chat that I want to just go through. Dr. Olalekan is saying, thank you for a wonderful presentation. Then he's saying, under the classification of cardiomyopathies, where does one classify sickle cell cardiomyopathy? Is it this dilated cardiomyopathy or restrictive cardiomyopathy or overlap? And then he's also asking, is there any relationship between sickle cell cardiomyopathy and sickle cell nephropathy? So Dr. Olosho, you can take that question.
Okay, thank you for the question. From the literature, they usually classify sickle cell cardiomyopathy under a restrictive cardiomyopathy. Or is a variant of restrictive cardiomyopathy in the sense that there's LV dilatation in sickle cell cardiomyopathy, which is not what we have in the other forms of restrictive cardiomyopathy. Also the relationship between sickle cell cardiomyopathy and sickle cell nephropathy. Well, I would say they are related because the mechanism, the background mechanism in sickle cell cardiomyopathy is also a part of what is responsible for sickle cell nephropathy, the fibrosis that occurs because of the microvascular occlusion, ischemia. So that's also when it occurs in sickle cell, in the kidney, can also be part of the pathophysiologic mechanism of sickle cell nephropathy in them. Apart from that, maybe cardiorenal aspects. I think that's what I can link with sickle cell cardiomyopathy and sickle cell nephropathy for now. Thank you.
Thank you very much. Dr. Olalekan, you want to add anything, or you're okay with the response?
Okay, thank you. Okay, well, I think looking at the classification, where does sickle cell cardiomyopathy falls? For me, I think probably is an overlap, but probably depending on the pathophysiology that is probably prevailing, because considering the restrictive cardiomyopathy, that's basically as a result of the iron overload that actually gives you that restrictive cardiomyopathy picture. So, but I also think that there could also be dilated cardiomyopathy aspect, which could also, and that was why I actually thought the possibility of probably there could be an overlap, not really being on one side, although I stand to be corrected on that. But considering the other response, I think I'm okay with that. Thank you.
Yeah.
Thank you. Sorry.
Okay. Go ahead.
I just have a comment on the response. First of all, the iron overload recent studies have shown that it's not really important in the pathophysiology of sickle cell cardiomyopathy. And also, of course, it has both features of both restrictive and dilated. However, it's more of restrictive because in dilated cardiomyopathy, we expect systolic, most times there is systolic dysfunction is usually prominent. However, in this form of cardiomyopathy, there is usually no systolic dysfunction except in the late stage of the disease. What predominates is the diastolic dysfunction in them. That's why it's most textbooks will say it's predominant restrictive cardiomyopathy, albeit a variant, not because it has a component of dilatation of the LV. Thank you.
Yes. Thank you, Olosho. Just a little addition to that. That study is they call it they publish it in Lancet. They call it state-of-the-art study. They have been demonstrated that the iron deposition is not a problem of the heart of the sickle cell anemia patients. 1, 2, if you do the echo on these people, you realize that they have relative improved systolic function especially in the radial component of systolic function estimation of the right ventricle. Now, but if you go to do the strain function of this patient, you realize that it is usually depressed. But if you just use the usual pulse wave transmitral and tricuspid estimation, and including TAPSE, you realize that these guys usually have improved systolic function. But the diastolic function is very severe. It's very severe. In fact, it's in the restrictive range. If you do like 30, 25 will be in the restrictive range. So it is an overlap here, really, no doubt, but it's predominantly a restrictive form of cardiomyopathy. Thank you.
Okay. Thank you for the comment. Still more comments on the chat. Dr. Ba is saying thank you, sir, for the presentation. A recap of the pathophysiology. Say it is multifactorial. Number 1, pulmonary hypertension. 2, chronic anemia and hypoxia. 3, transfusional iron overload. 4, systemic hypertension. And 5, alteration in the intravascular volume associated with vasculopathy and CKD. Well done. And then he's further asking, are you going to say a patient with sickle cell disease whose echo shows cardiomyopathy has sickle cell cardiomyopathy, or perhaps it should be a subset of restrictive cardiomyopathy or dilated cardiomyopathy? I think these has been addressed. Okay, so that's the last comment on the chat box. Are there any further questions before we hand over to our chiefs? Okay, so we'll take comment from Chief Adeyanju. Chief Adeyanju, you can please unmute and make your comment. Okay, it seems as if Chief Adeyanju is not close to it. Okay, she's posting on the chat. Let me just read that quickly. Thank you, Dr. Olosho, for a lucid presentation. The pathophysiology of sickle cell cardiomyopathy and pulmonary hypertension in sickle cell disease are areas to take note of. Emerging areas are speckled tracking pattern in sickle cell disease. Sorry, I'm in a noisy place. Okay. All right. So, Dr. Olosho, do you come across anything about the usefulness of speckled tracking in the diagnosis of sickle cell cardiomyopathy?
Yeah, thank you. I actually did not come across the use of speckled longitudinal strain in the diagnosis. What I saw mostly is CMRI, cardiac MRI, together with the other parameters of echocardiography, but I didn't come across. Most of the text I used did not mention speckled tracking. But like Chief On said, with the background vaso-occlusion, incessant ischemia, infarction, patchy infarctions, and the rest, they are bound to have impaired strain. But they still have most of the time with ejection fraction still most times preserved, especially in in the early stages. Thank you.
Yeah, exactly. I think it's an emerging area, and it will be very useful in detecting, early changes in systolic as well as diastolic function, and that can also help to take, precautionary measures before they go into overt cardiomyopathy. I don't know, Dr. Cyril, in your study, did you look at strain pattern or just the traditional way of looking at the EF and diastolic function?
Yes, the truth is that in my study, the strain pattern wasn't part of it. But while my study has been completed, I realized that, in fact, some of the earliest people that studied sickle cell, I took my book to them for vetting. They were insisting that I shouldn't write improved systolic function. That if you do speckle tracking, I realized that their systolic function is usually depressed. I got curious. I did extra 30, and I realized that speckle tracking and their systolic function is actually depressed, not seemingly improved the way I thought when I was using PAPC and the other parameters.
Oh, okay.
Tracking, you realize that they're depressed.
All right. Thank you very much. Okay, I think in the absence of any further comments or questions, we want to say thank you once more, Dr. Olosho, for a very good presentation. So we'll move over to the next segment of the discussion to look at the MCQs. And for that, I'll now hand over the class to Florence.